We'll have come to something which is relatively simpler. So the topic that I have been given for today is genetic cholestasis in children and adults. That is the easier part. The second part is, do we need an Indian registry in adults? I think that is difficult to answer, but let's see how it goes about. So my talk would be in three parts. What are the various genetic cholestatic disorders? Is genetic cholestasis common in adults? And what are the lessons learned from pediatric registries? Coming to the first part, what are the various genetic cholestatic disorders? There are mainly 5 subgroups of genetic cholestatic disorders. If I may classify them as those involving the biliary tree, then there are 2 main groups. One is the disorders affecting the small interlobular bile ducts, which are between the size of 15 to 100 micron, and these ducts are affected by mutations in JAGD1 and NOS2, which are involved in bile duct formation. So defect in them lead to paucity of these interlobular bile ducts, leading to cholestasis. Then there are defects in the microtubule formation due to mutations in DCDC2, which is a component of the microtubule, and defects in zinc finger YVE19. So these 3 mutations, including claudin1, lead to a picture similar to what is seen in PSC in adolescent and adults, where the larger ducts, the left, right, hepatic ducts, the segmental ducts, and the common bile duct will have areas of strictures, narrowing, dilatation, etc. The other 3 genetic intrahepatic cholestatic defects are those which are primary in the intracellular cholestasis. These could be disorders of bile acid synthesis, where the bile acid which is being formed from cholesterol is abnormal due to loss of various enzymes. There could be several enzymes, and these will lead to accumulation of abnormal bile salts in the hepatocytes, damaging the hepatocyte further. Then there is the PFIC spectrum that we all have been hearing over last several years, which involve the transporters at the canalicular membrane involved with the transport of the bile salts and their components across the canalicular membrane into the bile canaliculi. And then there is alpha-1 antitrypsin deficiency, which is not common in India. So coming to the part of intrahepatic cholestasis, because this is what is commonly has been described in adults, the rest have not been commonly described in adults causing genetic cholestasis. So if you see this, the most important, there are 4 most important proteins here at the canalicular membrane. This is the hepatocyte side and this is the canaliculi side. So the bile salt goes out through the bile salt exporter pump into the canaliculi. MDR3 located transports the aminophospholipid from the hepatocytes into the canaliculi. Now bile salts are dissolved by these aminophospholipid, and this forms a micelles. Now micelles are important because the cholesterol that is coming out from ABCG5 and ABCG8, these cholesterols have to be kept in a soluble form by these micelles. So if there is any abnormality, like any abnormality in BSEP, so bile salt will not go outside. So that will lead to accumulation of bile salt in the hepatocyte, leading to hepatocellular injury. Not exactly a cholestatic injury, it would be something like a hepatocellular injury. Now if there is defect in MDR3, bile salt will go out through BSEP, but will not get dissolved because of lack of aminophospholipid. So now bile salts accumulating in the canaliculi will mainly injure the biliary canaliculi and the bile ducts, leading to more of a biliary kind of injury in MDR3. And obviously, if there is defect in either BSEP or MDR3, the cholesterol will not get dissolved because the micelles are not formed, so leading to formation of stones. So this is something like if normally BSEP and MDR3 should be present at the canaliculi. So this is a immunostaining from one of our patients. Now this is a control. So BSEP should be present at the canalicular membrane, this dark brown thing, which is absent in the patient. And similarly, MDR3 should be present at the canalicular membrane, like in this control inset, which is absent in our patient. So now coming to the second part, is genetic cholestasis common in adults? And if yes, when to suspect it? Now the spectrum of presentation in adults with intrahepatic genetic cholestasis can vary from very mild or episodic to very severe, leading to cryptogenic cirrhosis, portal hypertension, cholangiocarcinoma, and SCC. Now the first 2 components, that is the ICP, intrahepatic cholestasis of pregnancy, DILI, drug-induced liver injury, and CIC, that is almost similar to ICP, that is contraceptive-induced cholestasis. These patients are usually those who have mild or heterozygous variants. So the protein is not very deficient. So these patients would usually be normal and only develop episodic or acute cholestasis when there is exposure to some drugs or exposure to elevated levels of progesterone or estradiol in pregnancy. The middle spectrum comprises these two things, that is low phospholipid associated cholelithiasis, which is mainly in the form of hepatolithiasis with cholelithiasis, and in the form of BRIC, that is benign recurrent intrahepatic cholestasis. These are patients with somewhat moderate kind of mutations who will have episodic cholestasis with resolution. And the patients carrying the most severe loss of function mutations will have the classical PFIC, which is usually considered a progressive form of cholestasis leading to cirrhosis and portal hypertension. So a recent study in adults with 356 patients with suspected cholestatic disorders were evaluated by genetic and whole exome sequencing, and the yield rate was 29%. So if you carefully select the cholestatic patients and then do a whole exome analysis, the yield can be as high as 29%. Among other things to note in this study was, this I will come to later, among other things to note in this study was, as is already widely known, that patients with ABCB11, that is BSEP, or FIC1 deficiency are likely to present in the infancy or early childhood. So that's why these patients only presented in adulthood when they were having a milder mutations, and that's why they somehow skipped these symptoms during their childhood. Whereas MDR3 can present in adulthood even if it has severe defects in the protein. So all spectrum of MDR3 can present in adults. So that is the difference, and that's why we found more of MDR3 in adult presentation. Now this can be better explained by this diagram, which shows the x-axis shows the amount of functional BSEP protein, and the y-axis shows the kind of diseases that can happen, and this shows the kind of mutations. So if the patient has severe mutations, the orange and the red part, the amount of functional BSEP protein will be close to 0 to 20%. These patients will invariably present with early onset cirrhosis or CLD. Whereas patients having around 25 to 50% of functional BSEP protein would actually remain normal otherwise. Only when there is an acute insult in form of drugs or hormones, this curve shifts downwards. So if a patient is still having 25 to 50%, but is exposed to drugs or progesterone or estradiol which lead to decreased BSEP function, how I will be showing in the next 2 or 3 slides, then they can develop symptoms or episodic cholestasis in form of DILI or ICP. In contrast, the curve is more or less slightly different in case of MDR3, where patients with even 50 to 75% of functional protein can still develop these symptoms of ICP or can develop late onset cirrhosis. So that is why we see these patients presenting for the first time even in adulthood. So coming to the 3 common presentations: DILI, low phospholipid associated cholestasis, cholelithiasis, and cryptogenic cirrhosis. So first I will come to DILI, and DILI is mainly associated with DILI in case of genetic cholestasis is mainly associated with drugs which are known to decrease the BSEP functions. So this study in Toxicology Science 2013 evaluated 250 compounds with various levels of grading by FDA, like those with black box warnings, those with warning with precautions, those without any adverse effect, and those with mild adverse effects. And among the 256 compounds, they found 86 compounds who were either strong inhibitors or weak inhibitors of BSEP, leading to decreased taurocholic acid transport. Among the strong inhibitors of BSEP, among the strong BSEP inhibitors were cyclosporin A, bosentan, and ketoconazole among the commonly used drugs. What they also showed that these strong inhibitors were more commonly found in drugs which had black box warning from the FDA, or drugs with strong as well as weak inhibitors were more common in drugs with warning with which were under warning with precautions. So this shows that BSEP inhibitors are associated with severe DILI and can lead to significantly reduced taurocholic acid transport due to BSEP inhibition. Now, one common polymorphism has been found in several European studies, that is this V44A polymorphism. We are saying polymorphism because this is otherwise has been shown to be by the studies, it has been shown to be not exactly causing PFIC, but a milder benign form of disease. But this polymorphism was much common in patients with NSAID induced DILI, 60% in this DILI versus 32% in controls, and this was also more common in drug induced cholestasis as compared to drug induced hepatocellular injury and healthy controls. What this study also shows, that drugs which contain a carbocyclic system with an aromatic ring, these kinds of drugs are the drugs which are known to inhibit BSEP intracellularly. Now, so this was the first study which I talked about, which described this common variant of V44A commonly. Then there are other studies which are registry studies have shown that again ABCB11 is more common in DILI than controls. Other genetic variants like ABCB4 or other genetic variants were not commonly found different between the two groups. So, this suggests that we should be careful, especially when we know that the patient has BSEP heterozygous or homozygous. We should avoid NSAIDs. Among the common antibiotics, amoxicillin, clavulanic and piperacillin tazobactam. Obviously, OCPs and anabolic steroids are a strict no-no. The recent study which I described previously, the hepatology communication study 2022, found a variant in 22% of cases presenting with DILI, and again the common variant was ABCB11 and the commonly implicated drugs were same, antibiotics, OCPs and NSAIDs. Now, one thing to note, that DILI associated with BSEP inhibition, R value will not be useful despite this being a cholestasis. This is because of if BSEP is inhibited, the bile salt cannot go out from the hepatocyte to the canaliculi, will accumulate in the hepatocyte and will cause hepatocellular injury as such, and there will be significant elevation of AST and ALT and less elevation of alkaline phosphatase. So, do not go by R value in these cases. Coming to ICP, which has been very well studied, the pathophysiological mechanism is very well showed by this hepatology study. We showed that there are two kinds of there are some females who develop ICP, some who do not. The females who develop ICP during their pregnancy have elevated level of this progesterone metabolite. This is PM5S is a progesterone metabolite during the later half of their pregnancy compared to controls. And this difference is not seen in patients who do not develop, the ladies who do not develop ICP during their pregnancy. What they also showed, that when they injected mice, pregnant mice with cholic acid, it led to elevated concentration of bile acids in them. So, it led to hypercholinemia, the second bar. Whereas, the third bar shows when they are injected with cholic acid in combination with this PM5S, this progesterone metabolite, this hypercholinemia shot up several folds. You can see it shot up several folds. So, this PM5S leads to severe cholestasis, hypercholinemia, possibly due to transient decompensation in ABCB4, that is MDR3 protein functions. There is another compound during the pregnancy which is elevated, and this comes from the mouse study in 2014. Now, this study shows clearly that estradiol, E2, estradiol level, this is the mice which is serially followed, and during the end of the pregnancy, estradiol level goes high and which comes down immediately after delivery. At the same time, as estradiol is rising, the amount of BSEP activity is going down towards the end of pregnancy, which comes back immediately after delivery. So, this study showed that estradiol, or it showed that clearly that as estradiol level goes up, the BSEP function, as the estradiol level goes up, the BSEP function goes down, and there is inverse correlation between them. So, coming to the studies, there are several studies in adults which have shown that both ABCB4 and ABCB11 by the mechanism that I showed previously are associated, and as many as 14 to 27% of ladies developing ICP will have one or more heterozygous or missense homozygous variants in ABCB4 or in ABCB11. There are some studies which showed less frequency, that is 3 to 3.5%, but these studies are limited because they tested for a single gene like ATP8B1, which we know is less likely to lead to intrahepatic cholestasis. So we'd like to believe that the number is much more high, as described in the recent study, where almost 47.5% of ladies with pregnancy associated liver dysfunction had variants in ABCB4 and ABCB11. Not only ABCB4 and ABCB11, other variants like ABCC2 and TJP2, if they are heterozygous, can also lead to intrahepatic cholestasis of pregnancy. What I would like you to note here, that normally we believe that MDR3 leads to high GGT cholestasis, but here the GGT is not elevated as much, possibly due to heterozygous state, but very difficult to explain why. But what is important is you should always test bile acid level, because bile acids are invariably elevated in these patients, and a level above 40 is predictive of adverse pregnancy outcomes, and level more than 100 is associated with stillbirths. There are other genes which are coming up. I'll skip them for a short of time, and I'll show more important, this we tried to look the other way, that one way you can look at it is what percentage of ICP have genetic cholestasis. The other way to look forward is, we have 369 patients with children with genetic intrahepatic cholestasis. We excluded those who were heterozygous because we don't know then the gene is coming from the mother or for the father, but we included patients with homozygous or compound heterozygous. So they will have at least one heterozygous mutation in the mother. We excluded those who did not have a data of history of ICP in mother. Among the remaining 269, when we evaluated the history of ICP, that was just on history taking, we found that 20% of the mothers reported having ICP in either this pregnancy with this particular child or in one of the other pregnancies which the mother had. And this was almost consistent throughout the spectrum. Obviously, ABCB4 and ABCB11, it was more than 20% of the mothers had history of ICP, but even in the others like USP53, MYO5B, TJP2, NR1H4, around 10% mothers still had history of ICP, significant ICP during the later stages of their pregnancy. Coming to the second part, that is low phospholipid associated cholestasis. I think the whole of the audience is well aware of this, that bile salt and phospholipid are both required to form micelles. If there is MDR3 mutation, phospholipid will not come, so the micelles will not form and cholesterol will precipitate. So it will be a lithogenic bile. If you examine this bile from the bile duct, then the cholesterol to phospholipid ratio will be very high, that is phospholipid will be low. That's why these patients are labeled as low phospholipid associated cholestasis, cholelithiasis. There are certain criteria to define this clinically, that is recurrent cholesterol gallstones in adolescent or young adult with a positive family history. This is essential. The intrahepatic calculi or sludge must be there. There can be exacerbation with pregnancy and OCB, and there can be recurrence after cholecystectomy. Now, there are studies which have clearly shown that ABCB4, that is MDR3, is clearly associated with elevated incidence of LPAC. What is important to note that almost 2 to 3%, 3 to 4% can go on to develop biliary cirrhosis in adulthood, in later, after recovering from this LPAC. And that is why the most recent guidelines of ESL, which has come just last month in July 2020, in the August edition of 2024, but was published online a couple of months back, mentions that these patients with LPAC should be followed with 6 monthly screening even for HCC, CCA and for development of cirrhosis. Obviously, the hepatobiliary malignancy, that is HCC and CCA, were more common in patients who were homozygous as compared to these hepatobiliary malignancy were more common in patients with ABCB4 associated LPAC as compared to non-ABCB4 associated LPAC. Coming to the third and last part is the cryptogenic cirrhosis. So, when you label a patient with cryptogenic cirrhosis without doing a genetic, it may not actually be a cryptogenic cirrhosis, and a significant proportion, that is varying between 18 to 20%, can have these variants, especially the variants with ABCB4 or the milder variants with ABCB11 or ATPB1, or even BASD that we have seen recently, these all can lead to cirrhosis, which may start later after 18 years of age and present to you as cryptogenic cirrhosis. So this is the same thing which has been shown in the most recent study, the largest study of around 140 patients, that around 5% of FIC1, around 10% of BSEP, and around 10%, more than 10%, 15 to 20% of MDR3 will have their first symptom or disease onset beyond 18 years of life. So I'll just show a typical case like how we miss these diagnoses. 16-year-old child came to us in 2017 with jaundice, very mild pruritus, and history of sibling death with CLD at 14 years of age, decompensated. We diagnosed him as AIH based on high IgG, autoimmune marker positive, 1:40 is given a score of 2 in pediatric, simplified score. Liver biopsy was suggestive, so the simplified score was 7. We started with steroids plus azathioprine. The patient had poor compliance to therapy. That's why when he came back to us after loss to follow for around 1.5 years, we thought this was due to poor compliance to therapy. The patient presented with another jaundice episode, which had resolved by this time, and there was persistent elevation of AST and ALT. We reviewed the liver biopsy. There was biliary cirrhosis that was mainly present. MRCP we did to rule out PSC, which was normal, and he was counseled for compliance and continued again. But after COVID, again he was lost to follow-up, and then he came to us in May 2022 with upper GI bleed. Somewhere during this follow-up, his pruritus increased significantly. By this time, because he was decompensated, he was already advised for LT, listed, and he underwent a LT in August 2022. By this time, an exome which was sent by us here came out to be positive, and the explant showed that patient had absence of MDR3 immunostaining and biliary cirrhosis. So the genetics came out to be compound heterozygous for ABCB4. So what were the points that we missed, or not missed exactly? We took these histories, but we did not give that importance to that. Possibly was one family history of CLD related death at 14 to 15 years of age. Pruritus was mild. We passed it off maybe as overlap, but MRCP was normal, so this could have been a red flag. And there was inadequate response to immunosuppression. So this recent ESL clinical practice guideline, which I was talking about, lists out the feature when you should go for genetic testing in adults. Now these could be acute cholestasis, like if there is severe ICP. Not every ICP you need to do genetics, but if there is severe ICP defined as bile acids more than 40, or early ICP starting at less than 32 weeks of gestation. If there is severe or recurrent DILI, either cholestatic or hepatocellular pattern, because I explained that it could mimic hepatocellular pattern due to elevated ALT, or in cases there are cryptogenic cholestasis, history of early onset gallstones, family history of liver disease, what was there in our case. Once you have excluded the common causes like PBC and PSC, and if there is atypical autoimmune liver disease, which was seen in our case. In addition, I'd like to add some more points from what the guidelines suggest. One is patients labeled as small duct PSC. Now there should be a definite doubt. There is nothing called small duct PSC, because possibly these children are all who have ductular proliferation due to MDR3 mutation, because you can see that in adults, when they undergo histology with MDR3 homozygous patients, almost all have small bile duct hyperplasia, and some have ductopenia when the disease has progressed. So patients labeled as small duct PSC, patients who are not responding to AIH on immunosuppression, and all cirrhosis which are unresponsive to their initial specific treatment should also be evaluated, I think. How should they be evaluated? Obviously, it should be NGS, and it cannot be Sanger sequencing, because you can never say by clinical picture which genetic mutation is going to come. So it's better to always do whole exome sequencing. Sanger is only when you know a family member with a particular mutation, then you can do Sanger. There is definite risk of cholangiocarcinoma. Around 3% patients can develop cholangiocarcinoma, and that's why the ESL recommendation is to do HCC screening and also for do cholangiocarcinoma screening, especially in patients with LPAC, patients with severe ICP, and in patients with cryptogenic cirrhosis. Now, the second type of patients that you can get as adult hepatologist is patients who started with their disease as childhood liver disease and are now transitioning to the care of adult hepatologists. This is because of now improved native liver survival and with or without improved native liver survival and improved survival with transplantation. So, what we know is that Alagille syndrome, almost 40% will transition to adult hepatologist. 30 to 45% of PFIC 1 and 2 will transition to adult hepatologist. BASD, we don't know the proportion, but it should be around same. PFIC 3, obviously those who present as pediatric disease will most likely transition to adult care, will not die, it is not as severe. And among NSC, around 40 to 50% will transition to adult care. How should they be screened once they come to hepatology OPD? Obviously, the regular LFT, GGT, all that is okay. Important points to note are serum bile acid is must, because that gives an idea of severity in all of them. AFP for SCC screening, cholangiocarcinoma screening, and UGI, especially in NSC, which is known to cause very significant portal hypertension, and in PFIC3, which can also cause significant portal hypertension. So, important thing is serum bile acid, CCA, cholangiocarcinoma screening, and upper GI screening. So, what lessons have we learned from pediatric registries that can show that adult registry is important? So, I think time is short, but I'll quickly go. One is the numerical advantage that can be had if you have registry, and once you have the numerical advantage, you can understand better the natural course of the disease. You can differentiate Indian genotype and phenotype from European and American patients, and you can explore the treatment options, prognosis, and outcome. Like in this study where we showed that once you make a diagnosis of TJP2 right at infancy, early half of infancy, first 6 months, right at that time, seeing the genetics, you can tell that this patient is not going to survive beyond 2 to 3 years of life, start preparing for LT. Or you can tell that this patient is going to survive with his native liver beyond 10 to 15 years, and thus you can just relax and continue with medical management.
Bikrant, just a minute. I want to tell everybody that this is the first paper in the world on TJP2. So this is the output of the registry.
Yes. So similarly, we have shown in DC-DC2 that this is a condition where 57%, no other condition bleeds so frequently. 57% patients had variceal bleed, and almost everyone had high risk varices. And once you do the endotherapy, if you don't have a response, these patients will have variceal bleed and will require liver transplantation. This slide is just to show that Indian mutations are different. And okay, I'll just come to the final. Therapeutics, yes. Having an adult registry is key to therapeutics like this wonder drug ASBT inhibitor, which is not available in India. If we have more involvement from adult hepatologists, we can involve the policymakers, we can have the logistic, we can have the financial goals so that these drug companies come to India. So, I'd like to conclude by saying that genetic cholestatic disorder in adults can be the first presentation in adulthood, or it could be a transition from pediatric to adult care. The Indian registry in adults are needed to define the magnitude of problem, understand Indian genotypes, clinical course, and outcomes. Because it is a relatively unexplored area, we will get a first mover advantage. Thank you.